live. Good morning, everyone. Welcome to PT on Ice Daily Show. My name is Jessica Davis, and I am coming at you from Pittsburgh, Pennsylvania. And I am the lead faculty for the Management of the Performing Artists course. So if you ever come and take my courses, we can talk all things dance. But today I'm going to talk about an orthopedic case, a unique case that I had because I think it's a good learning opportunity. It was for me. And you're going to find, of course, I'm sure you all know, there's moments in clinical practice where we have to do a little research and kind of brush up on some things when someone comes our way with a unique presentation that we've never seen before. So I thought I'm going to go ahead and just go through what went through my mind when I was learning about this patient. And I'd love to hear your thoughts and feedback too if you have any suggestions because this is an ever-exploring case. So here we go. So I have a 16-year-old, very competitive softball fast pitcher. That's a patient to me. And she came to me. She has had a 2-year history of what's going on. So I'm going to go through her subjective exam with you, and then I'm going to show you my body diagram. And we're going to come up with some hypotheses, or at least what was going on in my mind, and I'll let you know what has happened with this patient. So 2 years ago, when she was pitching, she noticed in her right more than her left. Now she's a right-handed fast pitcher. In her right hand, good morning everybody, by the way, hello. She experienced swelling. Now the swelling in her hands was on the dorsal aspect only, primarily in this region here. It would go up a little bit, so it was kind of like within this region in the hand. So it would swell, but what was interesting was it was both hands. So not just her pitching hand, it was both hands. Now, after she would pitch, symptoms would resolve 15, 20 minutes later. She had no pain, pin or needles, nothing like that. So she didn't think much of it. She just thought she's a young kid thinking, well, maybe I'm pitching too hard. She went to a pitching coach to work on her technique, but her symptoms never resolved. So fast forward, over the next 2 years, what started to happen with this patient was it always starts with swelling. So it would start with swelling. Well, then after the swelling would manifest, she would start to notice a tightness or a fatigue is how she described it, in both the medial and lateral aspect of her forearms bilaterally. Okay, so even though she's fast pitching with the right arm, she started to notice medial and lateral tightness. And then after that, so it would start with swelling, tightness, and then over time what would happen is she would lose control of her hands, both hands, and then she would have to stop pitching. So the duration of these symptoms, however, once she stops pitching, her symptoms alleviated and she had no limitations. Then over additional time, she started to notice that this was happening with daily activities. So specifically, if she were to work out and do anything where she had to grip or use her hands, carrying any weight or anything where she was involving using her hands with any resistance, she would start to notice again the swelling, the forearm tightness, and then eventual loss of control. So she went to her PCP, and her PCP did imaging of her hands. So she had x-rays. X-rays were normal. They sent her to PT, and PT sounded excellent. So she saw the PT for 3 months, and the PT worked on a variety of things. Worked on her pitching, worked on postural, muscular control. It sounded like did a lot of soft tissue work, did a good analysis based on what the patient was telling me. And the patient was also told, take a month off from pitching and softball entirely. So she took an entire month off. And then after 1 month off of being off, she then went for 2 months where she just worked on batting and she didn't pitch. Symptoms continued despite taking time off and despite PT. So the PT said, look, there's more going on. As we all do as PTs, we get to a point where we're like, we need to get further analysis. So sent her back. So she saw an orthopedic surgeon who diagnosed her with, actually, I'm not going to give it away yet because I want you to figure it out. I'm not going to tell you what the orthopedic surgeon said. She saw an orthopedic surgeon and basically was given a diagnosis and told to just stop playing softball. And then she was also sent to a vascular surgeon, and the vascular surgeon gave the same recommendation. Did some Doppler assessment. However, according to the patient and her dad, they Dopplered to the forearm. So Dopplers were negative. So basically this kid was told at this point, hey, nothing's working, just stop playing softball. The child, my patient, rightly so, is concerned because it's not just with softball that she's experiencing this. It's with any kind of activity that involves her using her arms. And she said, I want to live life and I want to be able to lift weights. I want to be able to use my arms, as we all do. So her dad found out about me and they referred her to me. So when I heard about this case, I recognized just from the phone call that something was unusual, or at least I haven't seen this before. So I started doing some research. And I want to show you the body diagram of this patient before I go into what I found with research and what we found in the exam, because this is what we teach at ICE, right? So here's her body diagram. So I'm hoping for those of you who are listening in the podcast, I'm going to just describe what you can see here. So if you look at the diagram, absolutely asymptomatic everywhere with the exception of the medial and lateral anterior forearm, medial and lateral tightness, and posterior lateral forearm tightness. And on the dorsal aspect of her hands, that's where she gets the swelling. Okay. She did report intermittent numbness and tingling that would resolve rapidly. So here's her current state. It takes 5 minutes. 5 minutes of pitching where she will notice the swelling. And within 10 minutes, she loses control of her hands. Within 15 to 20 minutes of rest, symptoms can completely resolve. She's 100% asymptomatic with the rest of her life. And she's a healthy kid, no other comorbidities. She's actually never had any injuries before, really no situations of illness. So PCP, blood work, everything else normal. So what I want you to think of right now, so if this was your patient and this is your body diagram, just based on the body diagram, what are your thoughts? Okay, so it's bilateral in nature, right? So we learn anything bilateral, we need to do what? We need to do a full neuro, don't we? Right? So we need to look up and see and make sure there was a report of numbness and tingling and weakness, right? So we need to make sure we do a complete neuro, including upper motor neuron, correct? Because it's bilateral in presentation. So I did do that on this patient. We also need to clear what? We need to clear the cervical spine, right? And for potential hypotheses, in my mind, the first one that came to my thought was chronic exertional compartment syndrome. Now, this is incredibly rare in the upper extremity. We talk about it in the lower extremity. It's actually prevalent in 95% of the cases. You see chronic exertional compartment syndrome in the lower extremity. In about 5% of the cases, there are historical reports of upper extremity involvement. The reason I was thinking this in my mind is my primary hypothesis is this with exertion, right? So she's asymptomatic, but with exertion this comes on. So that's what was a hallmark for me. And I thought potentially, right, there could be something vascular going on. Now, competing hypotheses that I need to think about, right? There could be neck involvement. There could be thoracic outlet. I could have anything anatomically that's in that area, right, involved. It could be shoulder. It could be elbow, it could be wrist, hand, it could be all different things that I have to clear. So I have to look at all of those things. It could be in a young kid. We could be dealing with some type of fracture, right? We know that that's more prevalent in young children. Not suspicious of that. And the reason is if you listen to the history, if it was a fracture, I would expect that the pain would be more prevalent. It wouldn't just be with exertion. It could be a muscle strain, right? It could be purely muscle. So in my exam, I have to take all of that into account. So I did a little research to see if there was anything out there about softball pitchers. And I found an incredible article. And as I always do, I'm going to post all of the stuff that I found. So I found something that was published in 2017 from the Sports Med Open. And it was a case report of chronic exertional compartment syndrome in the form of a collegiate softball pitcher. So this is very prevalent. This makes sense to me. I'm going to use this, right? Then I found a really nice article about management of chronic exertional compartment conservatively in the lower extremity in a triathlete. So this was of interest to me because I know historically that chronic exertional compartment often requires surgical correction, but I wanted to see what's out there that I could utilize potentially to address something conservatively because if I can help this kid avoid surgery, that's what I want. So I'm going to go through what I found, which was really interesting about diagnosing. But one of the articles and things that I found that was very interesting to me that I didn't consider and I needed to was something called Paget-Schroeder syndrome in athletes. So this is a nice article. It's a comprehensive and systematic review. I'm going to show this to you. And so if you look at this, this has to be on my differential diagnosis, and I'm going to explain to you why. So if we go back and look at just the anatomy of the upper extremity. Now, of course, when I was doing my anatomy, I couldn't find the dorsal aspect, but if we look up at the venous system, right? So anywhere along this line, if I'm thinking vascular, and of course we consider the venous or also arterial, but if we look at even just this on the hand, this is right around where she was having the swelling, right? But anywhere, even in the forearm, you can look at where in the venous system where there could be some disruption. Now, when I looked at her mechanics, so I did do slow motion analysis of her pitching, and it was fascinating. So within the first few minutes, she actually stopped and you could see redness developing in her hands, both of them, and you could see the swelling that started to manifest. And you could see, so her presentation, she does have terrible posturing. So forward head, very protracted shoulders. So her resting position is here. So if you look at even just the venous system of where she is, she could potentially be compressing proximally, right? Bilaterally. Because what I'm trying to figure out in my mind is, why is this not unilateral in its presentation? Because yes, she has a hyperabduction extension moment when she's pitching, and she has this poor posturing, very weak in mid-low trap scapular stabilizers, winging of the scapula noted. So very weak there, and does not, in terms of the proximal hip, weak proximal hip musculature and core. So there's things that I can work on soft tissue wise, very tight pec minor and into, the thoracic inlet, right? Very tight and tender medial and lateral forearm, incredibly tight. Nothing in my exam though, and I'm going to go back. Hold on. I'm going to go back into my exam in just a second. I want to tell you about this Paget. So another term of this is called an effort thrombosis. So this is a very neat article where it talks about, so this is something that we need to consider in PTs. It's very rare, but if you have a patient that presents this way, I want you not to miss this because this could be potentially harmful, right? So what happens is it's found in a very few percentage, 1 to 4% of athletes, young athletes, who work in repeated arm movements which cause the axosubclavian vein repeated trauma in that region. So what happens is you start to develop a fibrosis in this area. You can develop muscular hypertrophy, which can then create a clot that can form. And it's interesting. So it can cause an immediate pain and swelling, but it could also be intermittent in nature. So in my mind, this kid is intermittent, right? So it can be caused from some factors. They could have some hematological anatomical variations. They also may have thoracic outlet syndrome. Those are usually some of the precursors for developing this. And the pain will increase with exercise and decrease with rest of the extremity. So it also is attributed to hypertrophy of the scalenes in the anterior scalene muscular group. And it says there could be intermittent obstruction. So meaning that depending on the position of the athlete, they could intermittently obstruct. And then when they're out of that position, the symptoms can resolve. So this needs to be something on the list of our hypotheses, because one of the side effects, if this is misdiagnosed, is developing a pulmonary emboli. So something you don't want to miss, right? Now, when I went back and I spoke with Dad said, that she did see a vascular surgeon, but they limited the assessment to the forearm. So what we need to do with this athlete is she needs to have a further workup and make sure there's nothing going on centrally, right, in terms of the venous system. So her exam, completely negative. cleared the cervical spine with overpressure UPAs, even went in different ranges with different angles, different varying degrees of PAs, nothing. Thoracic spine cleared. First rib cleared. Negative cervical rotation lateral flexion test bilaterally. Negative Atson's test. So negative upper limb tension test, strength with the exception of what I described with some of the scapular weakness and core weakness in proximal hip. Nothing myotomally, no dermatomal distribution issues. Pulses were normal. Interesting though, the one test that was positive was the ruse test. Okay, so this is that hyperabduction, repeated. So after 1 minute, you could see that she started to develop the swelling in their hands. Now this makes sense to me, right? It should make sense to you because this is exertional. So symptoms did resolve, but that was the one positive test I found in my entire exam. So if we go back to this article that was describing the chronic exertion compartment system in the softball pitcher, what is nice about this article is it goes into properly diagnosing this, right? So things that you need to do, number one in diagnosing this is the clinical presentation, right? So classically, they will describe forearm pain or tightness, paresthesias potentially in the dorsal or volar aspect of the forearm. They will have hypersensitivity with palpation of the lateral or medial forearm, which she did. Benign, this is an asterisk. This is a benign clinical exam. So that's what I found, very benign clinical exam. And lack of Tinel's. Tinel's was negative on her. If you find that, what they also recommend is that this athlete should go through of different steps. Number one is no exercise for 1 month. She did that. Symptoms did not resolve. Put on a course of physical therapy. She had PT, and it sounds like from the description of that this was an excellent therapist. So PT did not help her. She was put on a course of anti-inflammatories. This is what they recommend. No change with that. Neuroconduction testing and all negative on this. So she did have that. What she hasn't had yet, which they recommend, is a cervical spine MRI. She should have a CT angiogram, which has not been done. Blood work was done, which was negative. Doppler, which was done, but based on this other, in terms of Paget's, you need to go up higher to do the Doppler. And X-ray was done, which was negative. So if all of that is negative, which you would expect, and if this is, then the next step, which is what she's going to have done, is a pre and post exercise MRI. And what you see pre and post is you should see swelling that's going to develop in the forearm or wherever the compartment that's involved. And they also recommend a pre and post intercompartmental pressure assessment. So this patient right now is we sent her off to another vascular surgeon for further workup. Waiting on all of that before we dive deeper into the proximal aspect and working on some of the postural muscles, because there could be, when I'm thinking about managing this conservatively, what do I have control of as a PT? I could work on what's going on up here, as well as work on some of the strength deficits I saw. But remember, the thing that keeps coming back in my mind is this is bilateral in presentation. So if this was just unilateral, then I'm thinking about pitching mechanics, but this is bilateral. However, bilaterally, she's significantly here. And so working on that scapular protraction, getting her to decompress if there is something going on proximally, could potentially have some improvement. But bottom line, we're still waiting to see what happens. But I thought this was a really unique case because in review, what I want you to do, so if you get a patient that has bilateral symptoms, oh, by the way, I did do a full neuro, everything normal. So negative, everything was negative on a full neuro screen. So interesting case. I hope this was educational in a way, and it would help you if you ever get a patient like this. If it ends up being exertional compartment, I'll get back to you and let you know. It would be very rare that that's the case, but it sounds like to me, I'm still thinking on my hypotheses that this could be going on, but it's important to rule out everything else. And we'll see what happens to her. But I hope this was helpful. And thank you all for listening, as always. Enjoy your Tuesday. Go out there and get it. And have a great day, everyone. Bye. Thanks for listening.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.